Hello, my name is Tom Smiley. I'm a pharmacist and educator from Paris, Ontario, and I'd like to thank you for participating in this accredited continuing education program entitled Antivirals for Influenza Prophylaxis and Treatment, a clinical practice refresher workshop for pharmacists. Every year there's much talk, and rightly so, about the importance of receiving influenza vaccine on an annual basis. However, given that many Canadians suffer with influenza each year despite vaccine efforts, it's also extremely important to understand the role of antiviral medications in the prophylaxis and treatment of influenza. The highest number of influenza cases on record in Canada occurred during the 2017-18 flu season. Thus, our discussion about antivirals for influenza prophylaxis and treatment today is very timely. First, though, a couple of housekeeping items. I have received a fee from Natco Pharma Canada Inc. for the development and presentation of this learning activity. This learning activity has received financial support from Natco Pharma Canada Inc. in the form of an unrestricted educational grant. Now let's have a look at our learning objectives. We will first review influenza surveillance systems, national, international, and local, that help to predict seasonal influenza outbreaks and facilitate early management. Secondly, we'll look at how the influenza virus is transmitted among individuals and the risks and symptoms associated with influenza virus infection. We will then identify circumstances that put individuals at higher risk for serious influenza symptoms and the important role of antiviral medications in these patient populations. Our fourth learning objective involves comparing and contrasting currently available antiviral medications for the prevention and treatment of influenza with respect to indications, dosage regimens, safety, effectiveness, accessibility, and cost. Finally, we'll review some resources and protocols that have been designed to better manage influenza outbreaks in various healthcare settings. To truly understand how different strains of influenza evolve, replicate, and ultimately cause influenza illness, we need to understand the makeup of the influenza virus itself. As shown in this diagram depicting a cross-section of an influenza virus, the virus contains 8 single-stranded RNA segments in its core. Also shown on the diagram are the hemagglutinin and the neuraminidase proteins that protrude from the cell surface. We also see on the diagram the matrix 2 or M2 proteins, which are integrated into the membrane of the cell. These 3 proteins are the most important antigens of the influenza A and B virus with respect to adaptive immunity against influenza. The process of replication of the influenza virus begins with the hemagglutinin protein binding to host cells via sialic acid-containing receptors at the cell membrane. After binding of the influenza virus to the host cell, the RNA strands contained in the virus enter the nucleus of the host cell via ion channels made possible by the actions of the M2 protein. The RNA viruses then utilize the host cell machinery in the nucleus to produce progeny influenza virions. In order for the progeny virions to be released from the cell, the attachment of the virus to the host cell must be broken. This is accomplished by cleaving of the sialic acid-containing bond by neuraminidase enzymes at the site where attachment of the virus to the cell host has taken place. This step can be prevented by the action of neuraminidase inhibitor antiviral medications, namely oseltamivir and zanamivir, subsequently preventing the release of the progeny virions. Although resistance to the neuraminidase inhibitors has been documented, the relative frequency of resistance is quite low, and thus these agents are the antivirals of choice when treating influenza, as will be discussed later in the presentation. There are 4 different types of influenza viruses, but only type A and B cause seasonal epidemics. Influenza A is associated with the most significant burden of illness and causes the vast majority of hospitalizations and deaths. Influenza A virus has been the most dominant subtype circulating in all but 2 seasons and is divided into subtypes based on the hemagglutinin and neuraminidase proteins that protrude from the cell surface. There are 14 different hemagglutinin or H subtypes, simply called H1, H2, etc., all the way up to H14, and 9 different neuraminidase or N subtypes, simply called N1, N2, etc., all the way up to N9. Only the H1, H2, H3, and N1 and N2 have been isolated in humans. Strains of influenza A are defined according to combinations of a particular H protein with a particular N protein on the surface of the influenza virus. For example, H1N1, H1N2, etc. This provides a large number of possibilities with respect to the number of influenza A strains possible. Mutations in the genes encoding the H and N glycoproteins during replication result in the constant emergence of new strains of influenza A viruses. Both influenza A and B viruses can cause seasonal outbreaks of influenza. However, antigenic variation occurs more slowly in the influenza B viruses, and influenza B occurs only in humans. Influenza B generally causes milder disease than type A. Influenza B viruses are not divided into subtypes, but can be further broken down into lineages and strains. Currently circulating influenza B viruses belong to one of 2 lineages, B. yamagata and B. victoria. Antigenic drift associated with influenza A strains can cause resistance to previously used vaccines. This is why a new vaccine is developed each year to cover 2 influenza A strains and 1 or 2 influenza B strains. When discussing surveillance of influenza activity in specific locations or regions, we need to understand terminology used in describing the level of influenza activity. In long-term care and acute care facilities, the term outbreak refers to the diagnosis of 2 or more cases of influenza-like illness within a 7-day period, including at least 1 diagnosis that has been confirmed by laboratory testing. For schools, daycares, and workplaces, it refers to greater than 10% absenteeism that is likely a result of influenza-like illness. The terms sporadic, localized, and widespread are used when referring to levels of influenza activity in a geographic region. Sporadic activity is associated with sporadically occurring influenza-like activity and lab tests positive for influenza with no outbreaks detected within a particular surveillance region. Localized activity refers to increased incidences of influenza-like activity and positive lab tests associated with outbreaks occurring in less than 50% of an influenza surveillance region, while widespread activity is associated with influenza-like activity and positive lab tests associated with outbreaks occurring in more than 50% of the influenza surveillance region. These definitions are utilized to show influenza activity in Canada. FluWatch is Canada's national surveillance system that monitors the spread of flu and flu-like illnesses on an ongoing basis. As you can see from the maps on this slide, the weekly FluWatch report includes a review of the level of influenza activity across the country. FluWatch reports are posted online every Friday and contain this and other specific information for health professionals on activity and strains of flu viruses circulating in Canada. The FluWatch program consists of a network of labs, hospitals, doctor's office, and provincial and territorial ministries of health. Program objectives include to detect flu outbreaks across the country as early as possible, to provide timely up-to-date information on flu activity in Canada and abroad to health professionals and interested Canadians, to monitor circulating strains of the flu virus, such as the H1N1, and assess their sensitivity to the antiviral medications, oseltamivir and zanamivir, and to provide information that the World Health Organization can use to make its recommendations on the best vaccine to use for seasonal flu shots. Now, the particular maps shown on the slide compare activity from December 17th to 30th in the 2017 season with a similar time period in the 2018 season. It is apparent from these maps that so far in the 2018-19 season, the level of flu activity is much lower than the 2017 to 18 season, with most of the country experiencing only sporadic activity during that time period. However, the level of activity of an influenza illness can change very quickly, which is the reason for weekly Flu Watch updates. The impact of influenza on public health varies from year to year, causing an average of 12,200 hospitalizations and 3,500 deaths annually. The 2017-18 season brought with it a seasonal high for influenza cases with over 64,000 reported. On average, influenza B represents from 26 to 34% of the laboratory-confirmed cases of seasonal influenza, but is usually more prominent later in the flu season. Approximately 70% of individuals hospitalized as a result of influenza are older than 75 years of age, and about 7.9% of this population dies in the hospital as a result. Almost all of the cases of influenza in older individuals that result in hospitalization are due to influenza A. The most common comorbidities associated with influenza in children are pneumonia and asthma. In adults, the most common comorbidities are cardiac conditions and respiratory disorders. Now it's time for the first of a number of questions that will test your current knowledge of influenza and its management, and will also serve to introduce the next segment of the presentation. So which of the following subtypes of seasonal influenza virus A caused the highest number of hospitalizations in the 2017-18 season? Was it A, H1N1, B, H2N3, C, H3N2, or D, H2N2? The answer to the question is H3N2 and is discussed on the next slide. This slide provides another example of information that can be found on the Flu Watch website and shows the number of lab-confirmed influenza cases in the 2017-18 season. The numbers here reflect the highest number of influenza cases in Canada over one season to date, and a very high percentage of H3N2 cases. H3N2 has the greatest impact on the older population and in people with comorbidities. The level of circulation of H3N2 is linked to seasonal surges in all-cause mortality and hospitalizations, influenza attributable pneumonia, and influenza hospitalizations, as well as respiratory and circulatory hospitalizations, and was linked to the highest number of overall hospitalizations in the 2017-18 flu season. Influenza B viruses became more commonly reported than influenza A viruses later in the season, in early March 2018 through May 2018, and represented 44% of the total influenza cases, a little higher than in the average year. Contributing to the impact of influenza caused by H3N2 was the finding that vaccine effectiveness was very low for that season, only 17% for influenza A and 55% for influenza B. Influenza effectiveness is measured according to the percent reduction in lab-confirmed disease incidence in a vaccinated group versus that found in an unvaccinated group. This graph from Flu Watch depicts the influenza strains found up until the end of December 2018 in the 2018-19 season. A total of 3,387 laboratory detections of influenza were reported, of which 99% so far were influenza A. Recall that influenza B usually does appear later in the season. 94% of influenza A viruses subtyped have been the H1N1 variety, which on average causes less severe symptoms than the H3N2 virus. Recall that in the 2017-18 flu season, the predominant influenza A virus was H3N2. This demonstrates the variability of prevalent strains that can occur from one year to the next. So far in the 2018-19 season, 68% of all influenza H1N1 detections have been reported in individuals younger than 45 years of age. And 63% of all the H3N2 detections have been reported in adults 65 years of age and older. The strains of influenza virus that affect the Northern Hemisphere each fall and winter season are largely predicted by the strains that have affected the Southern Hemisphere's winter season immediately preceding. The Global Influenza Surveillance and Response System of the World Health Organization monitors this activity, as well as the evolution of influenza viruses, to help inform the vaccine components that would be most likely to prevent influenza outbreaks in the coming season. Unfortunately, it's not an exact science, as viruses are continuously mutating to create new strains. The delayed time interval increases the chances that predictions for most active strains may have changed by the time the vaccine is used. The Global Influenza Surveillance and Response System also serves as a global alert mechanism for emergence of influenza viruses that have the potential to cause a pandemic. In order for the vaccines to be produced in time for influenza season in the Northern Hemisphere, the recommendations for vaccine components are made 6 months ahead. This time frame provides the viruses another opportunity to escape the effects of the vaccine by mutating before influenza hits the Northern Hemisphere. With respect to local surveillance, it is extremely important to identify influenza cases and outbreaks as early as possible, since prophylaxis and treatment regimens are most effective when started early. Surveillance begins in long-term care homes by establishing baseline levels of infection throughout the year for comparison to current levels. All staff must be educated to be aware of early symptoms of influenza and instructed to report suspected cases to their manager or other responsible individual as soon as possible. Responsible individuals must report any cases or clusters of influenza infection to local public health authorities. Any local, regional, provincial, or countrywide outbreaks must be reported. These all appear in the weekly Flu Watch reports. It's time for another question. When is an individual deemed to be contagious after being infected with the influenza virus? Is it A, 24 hours before the onset of symptoms, B, when the fever begins, C, when coughing begins, or D, 24 hours after the symptoms? The answer is A. Individuals are deemed to be contagious up to 24 hours before the onset of symptoms of influenza begin. This has implications for transmission of the virus, as discussed on the next slide. Prevention of the spread of influenza virus is the best means of preventing outbreaks. The influenza virus is most often passed from one person to another through airborne respiratory secretions by coughing or sneezing. Individuals should be taught to cover their mouth when coughing and to sneeze into a facial tissue if possible, or into their sleeve if there is not enough time. As we've just learned, an individual can pass on the influenza virus before symptoms appear, so practices for prevention of spreading of respiratory secretions should be ongoing, not just when one feels ill. For post-exposure prophylaxis treatment with antivirals, as will be discussed shortly, an individual should be assumed to be infectious from 1 day before symptom onset to 24 hours after fever ends. Infection Prevention and Control Canada indicates that an individual remains contagious for 3 to 5 days after onset of symptoms, and children may remain infectious for a week after onset of symptoms. There are many actions that healthcare providers can take in order to minimize the risk of transmission of viruses and subsequent influenza infection. These include receiving influenza vaccine themselves to help prevent transmission of influenza to their patients, using every opportunity to vaccinate people at risk, even after influenza activity has been documented in the community, discuss the risks and benefits of the vaccine with patients, as well as the risks of not being immunized, and teach patients about influenza prevention practices. This includes proper hand washing, coughing and sneezing etiquette as discussed, keeping shared surfaces clean, and what to do if a patient becomes ill with influenza. For healthcare professionals, we should disinfect all equipment shared among patients and all surfaces after the patient has left the area, and of course, practice appropriate hand hygiene. We should also use personal protective equipment, such as gloves and masks, when the circumstances indicate. A poster for informing the public of measures to help reduce the risk of the spread of influenza infection can be downloaded from the Government of Canada website at the website address listed. Time for another question. Which two symptoms of influenza are most often included in diagnosis? Is it A, cough and body aches, B, cough and fever, C, fever and sore throat, or D, body aches and sore throat? Although there are many symptoms that may be associated with influenza infection, cough and fever are usually present, with a couple of exceptions, especially with respect to elderly patients, which we will discuss. The term flu is often used very loosely. Cold symptoms are usually milder than the flu and do not include fever. When influenza has not been diagnosed via lab tests, then the term influenza-like illness, or ILI, is used. The official definition, as published by Health Canada, is high fever and cough, plus one or more of sore throat, arthralgia, myalgia, and prostration, as outlined in bold on the slide. Influenza affects the lungs as well as just the nose and throat. Additional flu symptoms, as shown on the slide, include headache, chills, loss of appetite, and a runny or stuffy nose. Sudden onset of respiratory symptoms with fever and cough, and with one or more of the symptoms outlined on the slide, is likely due to influenza. In children under 5 years of age, symptoms such as nausea, vomiting, and diarrhea may also be present. In patients under 5 years of age or 65 years of age and older, fever may not be present. It's important that our patients understand the difference between a cold and a flu. This poster is readily downloadable from the Government of Canada website. It can be used for display and to help counsel patients about when they do or do not need to see a health professional about their symptoms. The severity of influenza illness has been classified by the Association of Medical Microbiology and Infectious Disease Canada guideline, as outlined on the slide. Mild or uncomplicated influenza is described as typical influenza with no shortness of breath and little change in chronic health conditions. Moderate or progressive severity is associated with typical symptoms, plus symptoms such as chest pain, poor oxygenation, cardiopulmonary insufficiency, and CNS impairment. It could also include severe dehydration or exacerbations of chronic conditions. Severe or complicated illness is associated with signs of lower respiratory tract disease, CNS abnormalities such as encephalitis or encephalopathy, complications of low blood pressure, such as shock or organ failure, myocarditis or rhabdomyolysis, or invasive secondary bacterial infection. However, we need to keep in mind that 20 to 40% of patients with severe influenza A admitted to the ICU during the 2009 pandemic were previously healthy persons. This speaks to the importance of remaining vigilant of those patients originally seen with seasonal influenza that appears mild at the time, but may be progressing. It is important to identify individuals that are at high risk for severe influenza episodes as previously defined, as prophylaxis with antiviral medication may be indicated in particular circumstances, as we will outline shortly. Individuals at particular risk include the following: residents of nursing homes and other chronic care facilities, people 65 years of age and older who have a suppressed immune system, children younger than 5 years of age, Indigenous people, and all pregnant women. As will be reviewed, the antiviral treatment of individuals deemed to be at risk is more aggressive than those not at high risk for severe influenza symptoms. It's time for another question. Which of the following medical conditions predisposes an individual to severe influenza symptoms? Is it A, type 2 diabetes, B, renal disease, C, morbid obesity, or D, all of the above? Many medical conditions can predispose an individual to severe influenza symptoms, including those shown on the slide. Now let's take a look at additional conditions which may result in severe influenza symptoms. This slide lists chronic health conditions of adults and children that increase risk for severe influenza symptoms, as outlined by the Association of Medical Microbiology and Infectious Disease Canada. This includes cardiac or pulmonary disorders, diabetes and other metabolic diseases, cancer and other immune-compromising conditions, kidney disease, neurologic or neurodevelopment conditions such as seizure disorders or neuromuscular disorders, morbid obesity, children up to 18 years of age undergoing treatment for long periods with ASA, and anemia or hemoglobinopathy, example, sickle cell disease. And another question: which of the following antivirals is currently available as an interchangeable generic brand? Is it A, zanamivir only, B, oseltamivir only, C, oseltamivir and zanamivir, or D, neither oseltamivir or zanamivir? Oseltamivir is the only antiviral with an interchangeable generic brand available. Let's take a closer look at antiviral medication options for the treatment of influenza. Generic formulations are available for oseltamivir 30 mg, 45 mg, and 75 mg capsules. The generic version of the suspension is expected to be marketed for the 2019 and 20 season. Zanamivir is available as a 5 mg per blister dry powder for inhalation for use with an inhalation device or rotodisc. Oseltamivir and zanamivir are both neuraminidase inhibitors and, as discussed earlier, prevent release of progeny virions from the cell surface by inhibiting the action of neuraminidase enzymes. The price of adult doses of oseltamivir range from $3.12 per dose for generic version to $4.19 for the brand name. One adult dose of zanamivir powder delivered via rotodisc is $3.71. Amantadine was once a widely used antiviral for the treatment of influenza. It works by blocking the migration of the RNA strands from the virus to the host cell via the ionic channels facilitated by the M2 protein, as we discussed earlier. However, resistant viruses are now found to emerge rapidly in patients treated with amantadine. This explains why this drug is not used very often anymore for treatment or prophylaxis of influenza. In contrast, there is very little resistance of the influenza virus to the neuraminidase inhibitors oseltamivir and zanamivir. Antiviral prophylaxis of influenza with oseltamivir or zanamivir is recommended in the circumstances as outlined on the slide. While waiting for vaccine-induced immunity to take place in high-risk individuals, for protection of high-risk individuals in whom vaccination is contraindicated or has been deemed likely to be ineffective, for protection of patients at high risk and their family members and close contacts when circulating strains of influenza virus in community are not matched with the current seasonal influenza vaccine strains, For protection of family members or healthcare workers for whom influenza immunization is contraindicated and who are likely to have ongoing close exposure to unimmunized persons at high risk. And finally, to control outbreaks in closed facilities, antiviral drug prophylaxis combined with treatment and inactivated vaccine administration is indicated. Keeping in mind the risk factors for severe influenza just discussed, let's review guidelines as published by the Association for Medical Microbiology and Infectious Disease Canada for influenza antiviral prophylaxis for individuals in the general population, as well as for residents of closed facilities such as long-term care homes. For individuals in the general population that are not immunosuppressed, whether they have risk factors for influenza complications or not, prophylaxis is not instituted, but early treatment is instituted with oseltamivir only when symptoms arise. If significant immunosuppression exists, then presumptive treatment that consists of twice-daily doses of oseltamivir or zanamivir is instituted regardless of onset of influenza symptoms. Note that people at risk include those in close contact with an individual with suspected or lab-confirmed influenza illness. For residents of closed facilities where an outbreak has occurred, prophylaxis and treatment should be instituted as soon as possible as per the protocols of the particular facility. Now we move from prophylaxis to treatment for adults with mild or uncomplicated influenza as defined earlier in our presentation. For patients with no risk factors, where symptom onset has occurred within the last 48 hours, antiviral therapy with oseltamivir or inhaled zanamivir may be considered. However, if more than 48 hours has elapsed, antiviral therapy is not generally recommended, but the patient should be provided with instructions regarding indications for reassessment. For patients with risk factors, and it is within 48 hours of symptom onset, then antiviral therapy with oseltamivir or inhaled zanamivir would be initiated immediately. Now, in this case, even if more than 48 hours has elapsed since onset, treatment with oseltamivir or inhaled zanamivir may still be considered by a qualified health professional. Time for another question. Which of the following neuraminidase inhibitors is approved for use in a 6-year-old child with influenza illness of less than 48 hours duration? Is it A, oseltamivir only, B, zanamivir only, C, oseltamivir and zanamivir, or D, neither oseltamivir or zanamivir? The answer to the question is A, oseltamivir only, as discussed on the next slide. As zanamivir is only approved for children 7 years of age and older, only oseltamivir is approved for children less than 7. Antivirals are not approved by Health Canada for children under 1 year old, but based on the use of antivirals in this age group for some children during the 2009 pandemic, guidelines recommend assessment by a qualified health practitioner on a case-by-case basis. For children 1 to 5 years of age with no risk factors for disease and illness less than 48 hours duration, oseltamivir treatment may be considered but is not routinely required. For children 5 years of age and older with no risk factors for severe disease, antiviral therapy is not routinely ordered. We will discuss treatment of children 5 years and older with risk factors for severe disease on the next slide. Guidelines for treatment of patients 5 years and older with moderate, progressive, severe, or complicated disease are reviewed on this slide. Consideration should first be given to hospitalization and admission to the intensive care unit of a hospital. Antiviral therapy should be initiated immediately, even if more than 48 hours has elapsed since symptom onset. According to the Association of Medical Microbiology and Infectious Disease Canada guidelines, oseltamivir should be initiated first. If the patient is not responding to oseltamivir, or if onset of illness has occurred despite oseltamivir prophylaxis, or if influenza B has been confirmed or strongly suspected, zanamivir, preferably via the intravenous route, should be utilized. Now let's take a moment to think about opportunities for creating awareness with patients about the importance of antiviral prophylaxis and treatment during an influenza outbreak. Take a moment to jot down your ideas. I hope you came up with a number of opportunities for creating awareness with patients about the importance of antiviral prophylaxis and treatment during an influenza outbreak. A couple of opportunities might include during medication reviews, when patients are receiving flu shots, and I'm sure you came up with a number of opportunities as well. Time for another question. Are neuraminidase inhibitors recommended in Canadian guidelines for treatment of influenza in pregnancy? Yes or no? The answer to this question is yes, as we will discuss on the next slide. Pregnancy has been identified as an at-risk population for severe symptoms of influenza. Compared to non-pregnant women with influenza, pregnant women infected with the influenza virus are at greater risk for death. Influenza is associated with significant increase in stillbirths, premature deliveries, and infant mortality when women have influenza in the third trimester. The Association of Medical Microbiology and Infectious Disease Canada state that oseltamivir and zanamivir are Category C drugs. In other words, there are no controlled trials to assess their safety. However, no adverse effects on women or the fetus have been observed as a result of oseltamivir treatment. Oseltamivir was used extensively and safely during the 2009 H1N1 pandemic. Oseltamivir pharmacokinetics do not change from one trimester to another. Oseltamivir is excreted in breast milk, but in very low quantities. The bottom line is that as per Canadian guidelines, all pregnant women should be treated with oseltamivir in standard doses as soon as possible after onset of influenza-like symptoms. Now, the guidelines recommend oseltamivir in preference to zanamivir during pregnancy because it is systemically absorbed. This would likely deliver drug to virus-infected respiratory tract tissues more consistently than would inhaled zanamivir, especially in the later stages of pregnancy, when diaphragmatic excursion, limited by the gravid uterus, may impair necessary distribution of inhaled zanamivir through the respiratory tract. Now let's have a look at what the literature says about the efficacy of antivirals in preventing influenza. Based on their research, the Advisory Committee on Immunization Practices in the United States claims that when used appropriately, neuraminidase inhibitors are 68 to 89% effective in preventing influenza. A review by Jefferson and colleagues concluded that prophylaxis with oseltamivir reduced symptomatic influenza by 55% compared to placebo. A meta-analysis of studies conducted by Okoli and colleagues found oseltamivir to be 89% effective in reducing episodes of influenza compared to placebo. In general, the published literature suggests that oseltamivir and zanamivir are both effective in about 70 to 90% of cases when taken for prevention of influenza. Now let's turn our attention to the efficacy of antivirals for the treatment of influenza. A meta-analysis conducted by Jefferson and colleagues suggested that antivirals decrease the duration of influenza symptoms by 16.8 hours in adults and 29 hours in children. Similarly, a meta-analysis by Dobson and colleagues found that antiviral therapy reduced influenza symptoms by almost 18 hours in adults when given within 36 hours of illness onset. In a subset of patients with laboratory-confirmed influenza, duration was decreased by over 25 hours. Finally, observational studies of hospitalized patients with laboratory-confirmed or clinical pandemic influenza in 2009-2010 showed risk of death decreased by 19% for patients given neuraminidase inhibitors versus those who did not receive. This slide compares oseltamivir and zanamivir treatment in terms of dosage form availability, age indications, contraindications, adverse events, and availability of a generic version. We have previously discussed dosage form availability, age indications, and the fact that generic versions of oseltamivir are available. The oseltamivir product monograph does not list any contraindications for the product. The product monograph for zanamivir lists contraindications that include underlying respiratory conditions such as chronic obstructive pulmonary disease or asthma. Adverse events for oseltamivir include nausea and vomiting. Taking the medication with food can increase tolerability of the medication in this regard. There have been rare post-marketing results of elevated liver enzymes and hepatotoxicity, delirium, and self-injury with oseltamivir. Zanamivir adverse events have included allergic reactions such as oropharyngeal or facial edema, as well as diarrhea, nausea, nasal signs and symptoms, bronchitis, cough, headache, dizziness, and ear, nose, and throat infections. Note from the chart that oseltamivir is dosed according to weight in children 12 months and older, with the adult dose for prophylaxis being 75 mg once daily for 10 days, and for treatment, 75 mg twice daily for 5 days. Initiation of treatment should begin within 36 to 48 hours of illness onset. Also note that oseltamivir was temporarily approved for use in infants less than 1 year of age during the H1N1 pandemic in 2009 due to favorable risk-to-benefit ratio, but is not currently indicated for treatment of seasonal influenza in infants younger than 1 year of age. Use in infants should be handled on a case-by-case basis based on severity of illness. And it's time for another question. Which neuraminidase inhibitor requires dose adjustment in people with renal failure? Is it A, oseltamivir only, B, zanamivir only, C, oseltamivir and zanamivir, or D, neither oseltamivir or zanamivir? The answer is A, as we will discuss on the next slide. Dosing of oseltamivir in patients with renal impairment is shown on the slide. Note that anyone with a creatinine clearance of 60 mL per minute or greater can take the full dose. Recommended doses decline as kidney function declines as shown on the chart. Note that for prophylaxis, there is very little data once creatinine clearance reaches less than 10 mL per minute. No dosage adjustment is required for zanamivir in people with renal impairment. Doses shown on the slide are for all patients 7 years of age or older. Recall that zanamivir is not indicated in children less than 7 years of age. Provinces list generic oseltamivir as interchangeable with brand name oseltamivir, and most have a limited use designation where the criteria is for institutionalized individuals, as outlined on the slide. Saskatchewan has recently made treatment, but not prophylaxis, generally available through the provincial drug plan for all covered under the drug plan and extended benefits program. Most private drug plans will cover antiviral medications. Recall that a generic brand is available for oseltamivir capsules. And it's time for another question. Which residents of long-term care homes should receive prophylactic regimens of neuraminidase inhibitor when an influenza outbreak has been identified? Is it A, only those that have not been vaccinated, B, only those that have a medical condition that places them at high risk, C, all residents, or D, only residents over 65 years of age? The answer is C, as we will discuss. When an outbreak occurs in an institutional setting, all residents should be protected against influenza infection with antiviral medication. This includes prophylaxis for those who are not ill, as well as treatment for those who may be showing signs of infection. All unvaccinated staff members should receive antiviral therapy. If there is a mismatch between vaccine and circulating influenza strains, as occurred in the 2017-18 season, all staff members should receive antiviral medication prophylaxis. All antiviral medication dosing protocols should be started as soon as possible after the declaration of an outbreak. It is important that all institutions have a set of protocols related to respiratory infection outbreaks as outlined on the slide. An excellent resource is the Ministry of Health and Long-Term Care Ontario Guide to the Control of Respiratory Infection Outbreaks in Long-Term Care Homes. Templates for documentation, etc. are available in the appendices of the online document. Policies and procedures related to respiratory infection outbreaks should include education, outbreak-related policies and procedures, immunization-related policies and procedures, policy and procedures on exclusion, that is when a healthcare worker would not be allowed to work at the home during an outbreak, staffing plans and related policies and procedures, antiviral use related policies and procedures, specimen collection, laboratory testing and related policies and procedures, and importantly, communication related policies and procedures. So please refer to Appendix 9 of the reference for protocols and, as I said, for handy resources and templates. Policies and procedures for long-term care homes must include a section on antiviral use with reference to topics as listed on the slide. Appropriate use of antivirals, obtaining informed consent from residents or substitution decision makers to utilize the antivirals, obtaining medical directives by medical director for antiviral prophylaxis, payment, and reimbursement processes, as well as indications of oseltamivir and zanamivir, where possible, and a policy on staff antiviral use. Many long-term care facilities have instituted a may not work during facility outbreak or exclusion policy, which requires an employee to receive the influenza vaccine annually. If an outbreak occurs and the employee has not been vaccinated, they are required to receive antiviral prophylaxis. The sample letter shown is an example of a document adapted from the Ministry of Health and Long-Term Care Ontario Guide that should be on file for employees who choose not to be vaccinated. Please take a moment to have a look at the letter. The Government of Canada has published a comprehensive document entitled Canadian Influenza Pandemic Preparedness, Planning Guidance for the Health Sector. Influenza pandemics, or worldwide epidemics, occur when an influenza A virus, to which most humans have little or no immunity, acquires the ability to cause sustained human-to-human transmission, leading to community-wide outbreaks. Such a virus has the potential to spread rapidly worldwide, causing a pandemic. These novel viruses may arise through genetic reassortment, a process in which animal and human influenza genes mix together, or genetic mutation, when genes in an animal virus change, allowing the virus to easily infect humans. Pigs can become infected with influenza viruses from different species, and can act as a mixing vessel to facilitate the reassortment of genes from different viruses. Historical evidence suggests that influenza pandemics occurred 3 to 4 times per century. In the last 100 years, there were 4 pandemics separated by intervals of 11 to 41 years. Pandemics that have occurred in the last 100 years include the Spanish flu in 1918 to 1919, the Asian flu, 1957 to 58, the Hong Kong flu, 1968 to 69, and the 2009 H1N1 influenza pandemic. The pattern of disease is different in pandemics than in seasonal influenza. Pandemics may arrive outside of the usual influenza season and typically have more than one wave of illness. The total duration of a pandemic is likely to be 12 to 18 months. And during a pandemic, the new pandemic virus replaces other circulating influenza strains. Afterwards, the pandemic strain becomes part of and may dominate the mix of seasonal influenza A viruses. During seasonal influenza, most hospitalizations and deaths occur in the elderly and persons with underlying health conditions, whereas in a pandemic, disproportionately more severe disease and death is seen in younger people and in persons without underlying health conditions. Listed on this slide are a number of resources that you may use to answer further questions you might have on the prophylaxis and treatment of influenza. Now let's take a look at frequently asked questions by patients and how you might answer them. These are real questions that patients have asked pharmacists in the past. Question number 1. Is a course of antiviral medication effective for flu prevention for the whole season? Take a moment to think of the answer to that question. Well, the effectiveness of an antiviral lasts only as long as the offending virus is exposed to the antiviral. So, if there is more than one outbreak in a season, a course of antiviral therapy would be needed for prophylaxis of each individual outbreak. Second question. Can antivirals be given to someone that has been vaccinated for the flu? Think of how you might answer that question for a patient. Well, yes, in fact, antivirals are indicated during an outbreak for individuals who have been vaccinated and are waiting for the antibodies required for effectiveness to be produced. That's usually a period of 2 to 3 weeks from vaccination. Also, antivirals can be used in vaccinated individuals as prophylaxis when a circulating influenza strain is not well matched to the currently available vaccine, and as prophylaxis for treatment of influenza-like illness in patients not expected to have developed a protective antibody response to vaccination. This might be in frail and elderly persons or in immunosuppressed persons. And the third question. Are there special considerations with respect to dosing or timing of an antiviral medication taken for prophylaxis or treatment of influenza? Take a moment to think of your answer to that question. Well, in fact, yes, treatment is most effective when taken as soon after exposure or symptom onset as possible. In most cases, treatment is not provided if more than 48 hours have gone by since symptoms or exposure. For people with moderate, severe, progressive, or complicated disease, antivirals may be provided even if 48 hours or more has passed. And the final question. If a person thinks they have the flu, will an antiviral help? Think of how you would respond to this question. The term flu is often used to describe the common cold, so one needs to be careful here. If an individual thinks that they have the flu, they should visit a qualified health professional to discuss their symptoms and determine whether or not they are candidates for antiviral medication. I want to thank you once again for taking the time to participate in this accredited continuing education program about the use of antivirals for the prophylaxis and treatment of influenza. Now let's just take a moment to review some of the key take-home messages. I think it is very clear that seasonal influenza infection can be very serious and debilitating, and prevention is always the primary defense. Antiviral prophylaxis is indicated in cases where outbreaks need to be controlled in closed facilities such as long-term care homes, as a bridge during outbreak for a 14-day period after vaccination, for protection of high-risk individuals for whom vaccination is contraindicated, for protection of high-risk individuals in close contacts when the seasonal vaccine doesn't match the current seasonal strain, and for protection of at-risk individuals, close contacts, and healthcare workers for whom vaccine is contraindicated and likely to be exposed to unimmunized persons at high risk. Treatment with antivirals should occur as early as possible after symptom onset to achieve optimal outcomes. Treatment efficacy differences between oseltamivir and zanamivir are generally non-significant in healthy populations. Respiratory condition contraindications exist for zanamivir, and oseltamivir is approved for children under 7 years of age, while zanamivir is not. It is important to know institutional protocols in your place of practice, as well as pandemic preparedness protocols in the local jurisdiction. We hope that this program has met your expectations and learning objectives. Please obtain the evaluation using the link found on the slide. Once your evaluation is received, you will be sent a letter of participation indicating that you have earned one continuing education unit as per CEEP accreditation. This concludes our program. Thank you very much again for your participation.